Rahim. Assalamu alaikum. Another clinical neurological station, that is approach to a child with ataxia. The opening statement may be 15 years old girl present with difficulty in walking. Do the neurological examination. So, like other neurological station, first wash hand introduction, and then taking permission that today I'm going to examine Alia how he walks and wants to feel his muscle, how it moves, is it okay? And then going just little back and looking for is what's about the size of the head, is there any shunt present or not, and any scar present or not, any speech problem present or not, shaking hand, and skin neurocutaneous stigmata present or not, and then any contracture present or not, and is the what's about the dimension, is there any device present or not, and is he is any kind of distress or not, and then advise the child, will you please work for me? And whenever working, if we found that's a case, this is wide broad based gait, so we if it is obviously found that it is a ataxic gait, although we can confirm it by the only the tantrum working. After that we are confirmed about, and while he is doing the tantrum working, try to look that is there any piece cavus present or not. And after tantrum working, then to differentiate is it sensory ataxia or cerebellar ataxia, Rombax test. So different school has different ideas. Some school theories told that you can do the toe walking, heel walking, side of the leg walking, and some school told that no, just only whenever you found there is broad base gait, just confirm it by tantrum working. And then ask the child during the tantrum working, just suddenly turn. If it is cerebellar ataxia, it will be difficult for him, and then do the Rombax sign for the sensory and the cerebellar ataxia differentiation, and we will advise the child to put the legs together, embrace himself or herself by own hand, and then close eyes. And if it is sensory ataxia, he or she may fall down. If it is cerebellar ataxia, it will be Rombax will be negative. And then this is the standing position, we are doing this. Then we just immediately come to the back. In the back we are looking for, is there any kyphoscoliosis present or not, and if it is present, then we can to confirm if there is scoliosis, we can ask the child to bend knee. Okay, and then we will sit in front of the child, and we will in the face we are looking for, is there any telangiectasia present or not in the eye, nose, ear, upper chest, and we will wants to do the gaze provocated nystagmus, so that we will brought a light object, bright object between the patient and me, and then we will do the H shape movement whether there is nystagmus arises or not. And then we will do the dysmenesia, dysdiacokinesia, and dysdiacokinesia we have to check it in the both hand, and then we will do the dysmetria by finger. It is also called the finger nose test. Another video I am showing how to do this, and whenever do the finger nose test, we at the same time we also found the tremor, intention tremor present or not, and then we will do the rebound phenomena and hypotonia. After that, in the sitting position, we will do the knee jerks, either it is pendular or not. And if it is truncal ataxia, we will ask the child to embrace himself, and which side of the lesion he will fall down after closing the eye. And after this is the procedure, we have covered the standing. sitting. And now lying position. Lying position, we will check the hypotonia and reflexes and the Babinski sign present or not, also confirm the peace cavus present or not. And to complete my examination, I want to check the position and vibration sense and do the complete neurological examination, cranial nerve examination, cardiovascular system examination, for respiratory system examination as there is a scoliosis is present, and examination of the formal vision and the hearing assessment. Okay. Now present. So for the presentation today, I have examined Alia, who is 15 years old, working on ataxic gait, and rhombox is positive. She has hypotonia, absent knee jerk, and Babinski sign is positive. I want to do the position and the vibration sense. So what's your differential diagnosis is Friedreich's ataxia, ataxia telangiectasia, ataxic cerebral palsy. So if it is a case of Friedreich's ataxia, what will be the investigation? Investigation will be diagnostic investigation is genetic test, chromosome 9, and also there is lab test, random blood sugar, and imaging MRI of the brain and the spine, nerve conduction test, which will show there is decreased nerve conduction velocity, and also echocardiography for dilated cardiomyopathy, ECG, and also doing the test for lung function test and visual evoke potential, brainstem evoked auditory potential. And what would be the management? Management would be supportive management via the, through the multidisciplinary team, and team member will be neurologist, orthopedics, cardiologist, endocrinologist, as there is in case chance of diabetes mellitus, and speech and language therapist, occupational therapist, physiotherapist, genetist, and liaise with school, educational healthcare plan if needed, and social worker support group. And then the supportive treatment is gamma interferon, nicotinamide. And what are the prognosis? Usually prognosis ataxia and wheelchair bound at mid 20s and death at 40 to 50 years of age, 70% presence with scoliosis, and cause of death is cardiomyopathy, angina, arrhythmia. This all about Friedreich's ataxia. And same maneuver we will do for the ataxia telangiectasia, first of the gait, then back, then the, if we are confirmed, so the approach for ataxia. In the in case of ataxia telangiectasia, there is ataxic gait is present, and there may be rhombox is inconclusive. We can definitely say it is ataxia, rhombox is positive or not, and then scoliosis is present, and in case of upper limb there is findings also inconclusive, and in lower limb examination sometimes there will be normotonic and sometimes there will be decreased TPR, tone, power and reflex, and Babinski will be normal, and no pace cavus. Only on the face we can found the telangiectasia is present. And to complete the examination, we will say that we will want to do the complete neurological examination, cranial nerve, respiratory system examination, because there is chance of increased respiratory infection, and per abdomen examination for hepatosplenomegaly, because increased chance of reticuloendothelial tumor. Investigation is genetic testing, and other investigation in case alpha fetoprotein, decrease immunoglobulin A, immunoglobulin M, and CBC lymphopenia, and imaging MRI of the spine, brain, spine where we were looking for the tumor, MRI of the X-ray of the MRI of the spine for scoliosis, abdominal ultrasonography, and pulmonary function test if there is scoliosis, and fundus examination. In case of ataxia telangiectasia, we always want to avoid the ionizing radiation because it increases the risk of malignancy. So, always we will try to avoid the CT scan. And in case of ataxia telangiectasia, the complications mostly is the increasing the chance of lymphoreticular tumor and infection. In case of ataxia telangiectasia, there may be right lobectomy is done. So, while right lobectomy is done due to immunodeficiency, in case chance of infection, bronchiectasis occur for this reason. And management for ataxia telangiectasia, we will involve the neurologist, pulmonologist, genetist, occupational therapist, speech and language therapist, and immunologist for immunoglobulin transfusion, social worker. In case of ataxia telangiectasia, there may be Portakit for the immunoglobulin transfusion. And causes of death is in case infection and also the malignancy, and causes of recurrent chest infection due to decreased immunity, dysphagia, in case chance of aspiration, scoliosis, and improper physiotherapy. And the causes of ataxia is very important for the differential diagnosis in a case of video station with ataxia. So, acute, intermediate, and chronic. Acute cause is the infectious cause such as chickenpox, mycoplasma, measles, structural lesions such as tumor, hydrocephalus, and drugs, phenytoin toxicity, and vascular basilar artery thrombosis. Intermediate, migraine, epilepsy, inherited recurrent ataxia, and chronic is that neonatal encephalopathy, deadly worker malformation, Friedreich's ataxia, ataxia telangiectasia, vitamin E deficiency, E beta lipoproteinemia, and dysgenesis of the cerebellar vermis, Joubert syndrome. And it's very important for the ataxia, if we think about the pathway for the cerebellar and the spinal cord, for the proprioception, then the spinal cord there is first order neuron, and then the cerebellar. Ataxia occurs due to any point here. There may be sensory ataxia, cerebellar ataxia. In case of sensory ataxia, there will be ataxia present and rhombus is positive. But in case of cerebellar ataxia, there may be dysmentia and dysdiacokinesia, nystagmus, slurred speech. This is the two difference, but however, in case of Friedreich's ataxia, both of the presentation is present because it involves the posterior column as well as the cerebellar sinus present here. So, and how to differentiate the ataxia telangiectasia versus Friedreich's ataxia. So, in case of Friedreich's ataxia, it is most common, and followed by second common ataxia is ataxia telangiectasia. Friedreich's ataxia chromosome affected is chromosome 9, in case of ataxia telangiectasia 11, and gene is frataxin gene involved in Friedreich's ataxia. In ataxia telangiectasia, ATM gene, and both of them are autosomal recessive, and Friedreich's ataxia associated with pes cavus and kyphosclerosis, and ataxia telangiectasia immunodeficiency, increased risk of malignancy. Cause of death in case of Friedreich's ataxia, hypertrophic cardiomyopathy, ataxia telangiectasia, bronchiectasis, malignancy. Average lifespan 37 years in case of Friedreich's ataxia and 25 years in case of ataxia telangiectasia. Thank you very much. Assalamu alaikum.